Welcome back to It's Your Case, presented by VetCT.com. I'm Heather Chalmers, your radiologist on demand for this week. Today's example is a 1.5-year-old larger size mixed breed dog who's presenting for gagging and regurgitation. Now, last week we talked about the trachea, and today I want to stay in the mediastinum and talk about the trachea's neighbor, the esophagus. In patients that regurgitate, esophageal pathology is always going to be top of mind. But radiographically, not all esophageal pathology will be evident to us, especially with plain radiographs. The general categories of esophageal disease are structural pathology like a stricture or functional pathology such as a dysmotility disorder. Some conditions like esophagitis could cause both functional and structural issues, so there is certainly some overlap. Generally speaking, when we're talking about plain radiographs, we're looking for structural or changes in esophageal size. We can't often comment about the functional aspect of the esophagus with plain radiographs unless we do an esophagram. Esophography is excellent if available with fluoroscopy. It can also be done with plain radiographs by making serial radiographs, but this can be quite cumbersome in practice. So I want to start by pointing out what many of you have already noticed. We're all very familiar with the esophageal stripe sign, and often it jumps off the radiograph at us. What I want to kind of take the time to tease out is what is the actual anatomic feature that creates this sign, because understanding that can help us understand when it could be normal and when it's an abnormal finding. The esophageal stripe sign, which I've delineated here with the blue arrows, is essentially a summation of the soft tissues of the ventral wall of the esophagus and the dorsal wall of the trachea. The stripe shows up really well because here we have soft tissue opacity in both of the walls, outlined or contrasted by a different opacity, which is gas. So ventrally, it's well delineated by gas within the trachea, and dorsally, it's well delineated by gas within the esophagus. So simply seeing the tracheal stripe isn't always pathologic. Especially on a left lateral view, we sometimes will see the tracheal stripe when there's just a small amount of esophageal gas. But what I don't expect to see as frequently is the dorsal esophageal wall, and especially when I can see the dorsal esophageal wall, I then like to get a sense of how large is the esophagus. So simply seeing the tracheal stripe is not enough. We also want to know, is the esophagus enlarged? So in this case, if I were to measure from the dorsal esophageal wall to ventrally here, you can see that we have quite substantial enlargement of the esophagus. The tracheal stripe generally is considered to end at the carina. That's because, as we already defined, the tracheal stripe specifically refers to that summation of the tracheal wall and the esophageal wall, but we can still see the ventral esophageal wall here all the way into the caudal thorax on this case. Going back to this view, you can appreciate that this is also the case on the right lateral view. So we see the esophageal wall here, just dorsal to the caudal vena cava, which is this soft tissue opacity here. The ability to see the esophagus caudal to the heart on the lateral views is variable. Occasionally, especially on a left lateral view, occasionally you will see the esophagus caudal to the heart, but you should not see the dorsal esophageal wall this high up. So in this case, we have increased esophageal size. We have this very obvious tracheal stripe on all views. We have adequate visualization of esophageal enlargement caudal to the heart. And once we're concerned about diffuse esophageal enlargement or megaesophagus, the next thing that's going to be top of mind is assessing the lungs. Let's take a minute to look at the ventrodorsal view in this case. Okay, so on the ventral dorsal view, the reason that I like this is we can get a bit of a sense of increased opacity in the lung that's distributed not diffusely, but in particular locations. So you can see in the left cranial lung lobe here, maybe slightly worse in the caudal subsegment, we have diffuse increased opacity. We also have increased opacity here in this region. This is the location of the right middle lung lobe. When I would categorize this pattern, I would definitely call it an alveolar pattern. That's because in the areas where the lung is affected, I'm not able to really delineate pulmonary blood vessels. So compare the lack of visualization of pulmonary blood vessel here in the region of the right middle lung lobe versus here is a blood vessel branching into the right caudal lung lobe, and I can actually trace it all the way out to the perimeter here. So, concurrent findings in this case is cranioventral alveolar lung pattern, highly consistent, of course, with aspiration pneumonia. I'm calling it cranioventral because on the lateral view, we would see that it's mostly this increased opacity superimposed on the heart in the left and right, left cranial and right middle lung lobes. Whereas in the caudo-dorsal lung fields, we can see, of course, the esophagus is superimposed, but we can see adequate visualization of pulmonary blood vessels. So to summarize, here we have a classic case of diffuse megaesophagus, secondary aspiration pneumonia. The next steps will include treating for pneumonia, of course, and a medical workup to determine the underlying cause of megaesophagus. This might include screening for infectious disease, endocrine pathology, myasthenia gravis. Often esophageal motility studies such as an esophagram could also be helpful, and potentially endoscopy to kind of have a complementary assessment of the luminal pathology such as concurrent esophagitis. So be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post any questions on social media.